Hi, and welcome to the cervical spine. We're going to look first at concerns on post-traumatic patients, particularly with serious pathologies. So here we go. Indicators of serious traumatic pathology will be a headache, dizziness, torticollis, and immediate severe central pain. Now, all of these are symptoms that don't necessarily denote severe disease or severe pathology. But these are things that you have to be really careful of, particularly in post-traumatic patients. So we're going to talk about null hypotheses and disproving them, essentially. So just a quick review of the type of headache we're talking about. So, psychogenic, the spondylogenic headache coming from the spine tends to be superficial. It's felt in the bone. It's easily delineated. The patient can easily tell exactly where it is. The typical distribution is suboccipital, occipital, occipitofrontal, and sometimes retroorbital, or sometimes it will do the same but come around the temporal area and then into the eye. Unfortunately, VBI can give you a similar, if not this identical headache, except that this is pretty much always confined to the posterior head. So the distribution between spondylogenic headache that only affects the occipital area and VBI headache, there's no difference in the quality or the distribution. Dizziness. Before we get off of headaches, the typical headache of an intracranial bleed is dull, diffuse, deep, and not delineable, and is progressive. So that one stands out considerably. Dizziness, vertigo is fairly easily classified into central versus peripheral. Central vertigo tends to be mild to moderate. It's long lasting. It persists long after the trigger is gone. It can alternate in direction, and also you need to be careful about stuff that is dizziness that isn't around a vertical axis. So somersaulting forwards or backwards, particularly backwards, is not good. However, type 2 dizziness really doesn't lend itself to being easily classifiable, and I think probably the only thing you can do, first off, if they have nystagmus with type 2 dizziness, which is pre-syncope, so lightheadedness, giddiness, so on. Nystagmus occurs with vertigo because of a screw up in the vestibular ocular reflex. This isn't the case here, so nystagmus must always be considered to be neurological rather than neurophysiological. Otherwise, type 2 dizziness that goes on for more than about 15 minutes and is showing no signs of improvement should be treated as serious. An immediate onset of torticollis, not severe torticollis, but torticollis or any deformity after trauma as an indication of a fracture, dislocation, and so on. As is immediate severe central pain. In fact, with emergency technicians, central pain with tenderness immediately indicates a fracture to them, and they will automatically keep the patient very still, try to get a hard collar on them, and then whip them in quickly as they can. So these are the four major indicators of serious pathology. So the pathologies we're interested in here are high cervical fractures. Now, you're going to get fractures, intra-articular fractures, sometimes fractures of the pedicle, sometimes the transverse process, but we're talking about stuff that's particularly dangerous. So high cervical fractures and dislocations. You can certainly get partial dislocations. These are the anatoaxial rotary fixations, and we'll discuss this in future. But these things are a threat to the spinal cord. Intracranial bleeds, mostly these bleeds are rapid and it's not going to be an issue for you. But occasionally, especially with older patients at higher velocity traumas, these can be slow as the veins are damaged, and it occurs by shearing forces and torque forces. So this can be slow rather than fast, and this can take up to 2 or 3 weeks before the crisis occurs. So the real key here is progression of a headache. VBI is, of course, the other one, and this is denoted by, not by the 5 Ds, but by headache and dizziness. And what we're going to look at is coupling and decoupling them from each other and from the neck. And there are radiotranslucent serious damages where they're not going to show up on x-rays. These are things like rim lesions, articular fractures, ligament tears, and so on. Now, these are serious for the patient, but not necessarily serious to the patient's health. So I'm not going to spend too much time with these, but understand that anybody with an acutely painful neck with loss of range of motion, this may be traumatic arthritis, or it may be more serious damage, and the prognosis for this is going to be worse. So all of this is stuff we're going to take into account. So how do they tally up? This is sort of the average, what you can expect to see. So high cervical fracture, they're almost certainly going to have headache just from referral up from the fracture site. Dizziness may or may not be present. It really depends on how long they've had it. The longer they've had it, probably the more likely they are to get dizzy. But dizziness can also be part of shock. They feel nauseous and sick and everything else. So there may or may not be dizziness with this. Torticollis or a step deformity occurs with this, and there is immediate severe central pain. Now, we're not talking about minor fractures. Fractured dens that doesn't displace very much, so you're not getting neurological symptoms or signs, falls into this category. So does, as I say, ARFs, atlantoaxial rotary fixations, where there's a true partial subluxation or dislocation of the AA joint. All of this fits in there. So you may not be able to tell it's a fracture, but it's going to be something that you don't want happening. Similarly, central ligaments tearing will give you a very similar pattern. Intracranial bleeds, the big thing about the headache is that it's progressive. It starts off mild and gets worse and worse and worse. And it may take a while before you start seeing cognitive change like drowsiness, concentration difficulties, and so on. And by the time motor effects have started to happen, then the patient's in severe trouble. There may or may not be dizziness. This may be due to cerebral concussion or the damage to the cerebrum, or even to the brainstem. BBI, there will be headache and there will be dizziness. Almost certainly headache and certainly dizziness. A couple of studies have shown that dizziness is 100% present with traumatic BBI, and headache is almost as common. So these two are also symptoms of spinogenic pain. So we need to investigate a little bit further. Traumatic arthritis will give you a headache. It may possibly give you dizziness, but the immediate severe pain, as with BBI, isn't there, and there will be delayed severe pain over time as the inflammation becomes more larger, bigger. And severe damage, there probably will be headache depending on where this damage is occurring. There may be dizziness over time. There may or may not be torticollis, and there probably will be immediate severe pain. So when we're talking about severe damage that isn't particularly radio-opaque, we're talking about rim lesions, that's tears through the vertebral body, or the end plate, or the disc. Central ligament tears, jump facets is the complete dislocation of both facets, or one facet. It'll come right over the top that way. They'll sit back to back now rather than face to face. And this could be unilateral or bilateral, and they don't show well on the x-ray if they show at all. And then disc herniations and so on. So all of these things are possible without the x-ray showing anything whatsoever. And it's worth noting that some of these severe traumas can walk about quite normally in a lot of pain, but they're ambulant and they're functioning as far as the pain will allow them. So we can't turn around and say this isn't an issue. So we can look at a process, and as I say, what we're doing here is coming up with the worst case scenarios and then disproving it, hopefully. So we've got cervical trauma. Probably your biggest issue here is a fracture, high cervical fracture or a major dislocation. These you definitely do not want to be moving around. So your H1 is serious fractures and dislocations. So you're looking for a sudden onset of the severest pain within an hour or so of the accident to overcome that pain where you can mediate it with your pain modulation systems. Central pain and tenderness to gentle, and I emphasize the word gentle palpation, a deformity. That's an immediate torticollis or a step deformity. The C-spine rules being breached is an indication or an X-ray, not necessarily a trip to the emergency room. And I'll try to make that clear up there. If this is refuted, then the next most dangerous one is the intracranial bleed. You have no idea when this patient's going to keel over. This one you can move about, but you really don't want to. If you can avoid it, it needs to be gone out. So headache is progressive, deep, dull, and diffuse, and is gravity dependent. That is, if they put their head down, doing shoes up, laying on that side, the pain increases. And it's as the brain actually pushes on the hematoma and pushes that against the skull, then basically this is when it becomes painful. So again, that needs to go to the ER because you can't send it to the family doctor. You have no idea how much they've got, how much time they've got here. If it's refuted, we can start thinking about VBI. Now, it's not necessarily that VBI is less dangerous than the other two. It's just that if they survive long enough to see you, unless you start moving around, they're probably going to be okay until an embolus is released, and you really don't want to do that. So you're looking at dizziness and posterior headache. These are pretty much always going to be present. If you can couple the headache and the dizziness, that is, the headache's always there when the dizziness is there, and the same thing is aggravated. So they're never there separately, they're always together. But you can decouple both of them from the neck pain. That is, they're not reliant on the neck pain being worse. Things that aggravate the neck don't necessarily aggravate the headache and dizziness. So, coupled headache and dizziness decoupled from the neck is about the worst case scenario. After that, you have to make a judgment. So if they're often absent, but or sometimes present with a neck pain, you're probably better off assuming they've been decoupled. But this is a judgment issue. If there's neurological symptoms, get it out. And if you find neurological signs in the cranial nerve exam or in the spinal cord, all of that goes out. So if you accept this, it goes to ER. If it's refuted, you continue on with the exam. Remembering, though, that this could easily be a severely injured neck that isn't showing up in any of this stuff. So you're always going to be careful with these post-traumatic pain, even if you've refuted these three hypotheses. So I hope that helps, and we can discuss this anytime you want to. Okay, guys, thanks very much. Have a good week. Take care. Bye.